Thank you very much. Assalamu alaikum once again, and thanks for the opportunity to be with you to discuss this important issue about injectable therapy during Ramadan fasting and making it to go from theory to practice. It's important for all of us to, first here are my disclosures, and good glycemic control throughout the year is paramount. Whether the person is Muslim or for any other religion, whether they want to fast or do not want to fast. Glycemic management is really important. At the end of the day, Ramadan is 1 month a year. Unfortunately, when I look into data from our DAR Global Survey, the minority, 36%, have an HbA1c of less than 7.5, which says that there is a lot of room for improvement in glycemic control. In fact, when I looked into people experiencing significant hyperglycemia, you can clearly see that 16.3% experience significant hyperglycemia, which is even slightly higher than hypoglycemia. So that's something that we need to improve. This freestyle Libra chart of the blood glucose level in Ramadan close to the time of Maghrib is at its best, and then even someone with hyperglycemia, and then come the Maghrib time and iftar, the feasting is continuous throughout the night. And that's something that we see a lot. So let's apply this in a couple of simple case scenarios. I have here Ahmed, who's a field engineer with background diabetic retinopathy with type 2 diabetes that he had for a number of years with an HbA1c, 8 years he had type 2 diabetes. His BMI is 29, HbA1c is 8.4. His fasting is not too bad on 106, but his pre-meals is nearly 200 or 11 millimoles. He's already on 1,500 milligrams of metformin, empagliflozin, and he's on twice daily Novomix 30. Now, he's been experiencing hypoglycemia during the week, perhaps on days related to his lifestyle, his work as a field engineer, maybe out of office, maybe on his foot, not taking the right amount of food, and that the hypos were the limiting for him to up-titrate his insulin. And he's very keen on fasting, as he always have. And he comes to you now, before Ramadan, by maybe 2 months or so. So I start thinking of this case and start thinking of the problems of the person. The fact that the person has twice daily mixed insulin. He has a stable lifestyle with stable working hours. His work is not terribly physically demanding, but certainly is not pure office job. And hence his frequency of hypos of 2 to 3 times per week. His glycemic control not being optimal, specifically, I would say it's poor for someone in the mid-40s. He is doing regular SMBG and he wants to fast. So if we start thinking of the level of risk, and instead of applying our subjective process, let's apply a systematic process through the risk calculator, whether on the application or online or on printed format. So I would start to mark him having multiple weekly hypoglycemia with 3.5 points. He is on twice daily mixed insulin on top of oral therapy. The oral therapy is on scores 0, but the twice daily mixed insulin scores 3. His HbA1c is in the 8.4, so that gives him an extra mark. He does not have cardiac, renal, or acute complications, and he's doing the blood glucose monitoring frequently, so that scores 0. As we said, his job is mostly an office job, but with some physical activity. I wouldn't really say moderate intensity. I would score it as 0. His hours of fasting are less than 16. He's not old or frail, and his previous Ramadan experience was fine. So when you add them up, they come with a score of 7.5, which indeed is a high score. So Ahmed would need to be advised, if his situation remains the same during Ramadan, then his score is very high or high, and he's advised not to fast. But probably we can reduce his risk because almost all his risk factors are modifiable. The frequency of hypoglycemia is modifiable. The therapy that he's on is potentially modifiable. And the glycemic control level is modifiable. When you add these points, that's 3.5 and 6.5 and 1 point, that's the 7.5 points that he scored. So we need to try to improve his glycemic control because this is crucial for his overall health. And the question whether we intensify the dose, I would say that maybe with increase his hypos. If I switch him to basal bolus, it might improve his glycemic control, but I'm not sure whether it would reduce his hypoglycemia or not. Adding a DP4 inhibitor would not reduce his hypoglycemia, might improve his glycemic control. Switching to basal insulin plus a GLP-1 receptor agonist, whether a free mix or a combination mix, could well be a good option. All of them are good options, but with pros and cons. We're trying to see what is the most that suits the lifestyle of Ahmed, being a Muslim person who wants to fast. So again, this is the highlight of the score for the therapy. And let's look into how therapy can improve things. We know from the ADA ESD guidelines that combination of therapy of insulin as well as GLP-1 would be considered among the very high options for glycemic efficacy. And obviously, a GLP-1 is among the options that would help to prevent weight gain and indeed reduce weight. GLP-1s in Ramadan studies have been shown to be effective. They do what we know they do. They reduce HbA1c, they reduce appetite, they make people less hungry, which is very useful in fasting. They make the person feel full so they don't overeat. So that helps reduce HbA1c and postprandial peaks, which we see in Ramadan. By virtue of how they work, they can help to reduce weight. And the process itself does not cause much of hypoglycemia. It's a rarity. And the studies in Ramadan has been a number of studies which have proven that this works in Ramadan as well, whether data on lixexenatide or on liglitide. This has been shown in few of the studies. What we also know from efficacy trials of basal insulin and GLP-1 receptor agonist in fixed ratio combinations of the available data that is being published, that the pathophysiological of combining basal insulin GLP-1s help to reduce the fasting plasma glucose as well as the postprandial glucose excursions. And doing this would reduce both the fasting plasma glucose and the postprandial, reduce the glycemic control, minimize the number of injections, improve adherence by reducing complexity and reducing the burden on the person. What about what happens in Ramadan? Well, we did do the Ramadan Soliram trial, which was published almost 2 years ago to the day almost. And when I look into, for example, what happens in the sub-analysis from Gulf countries, we know that in Ramadan we eat more and we have less physical activity. And the combination of these two things together makes sometimes the hyperglycemia of more of a concern rather than just the hypoglycemia. So what we did and we saw in the baseline characteristics of the people who joined the study, all being given it's as an observational trial, the IGLAR-LIXI in a fixed ratio combination in single pen, but they will also over 50% of them on metformin and over 40% are on either sulfonylurea or SGL2 inhibitors. The vast majority of people elected to take the daily injection at the evening, and small number of 11% took it at suhoor time. Fasting was practiced. Over 25 days of fasting was practiced by 97% of the population of the study. Mean number of days of fasting were nearly 29 days. And those 7.6% who broke the fast, the vast majority of it was not related to hypoglycemia or diabetes-related issues. Only 4 persons broke the fast because of hypoglycemia. Indeed, when you look out of Ramadan, 1%, 4 people out of the 410 persons who took part in the study had hypoglycemia. During Ramadan, that increased to 2.3%, and which was constituted to 9 individuals. And post-Ramadan, what was lower? The majority of the hypos were during the fasting hours. But these hypos were mild. When you look into the more significant hypo of less than 54, that was 0.5%, precisely 2 people out of 394 persons. And this occurred during the fasting hours. There was no severe hypoglycemia during the study, which is quite reassuring. Now, it's quite interesting when I look into the profile of the geographical distribution. It does look like, for some reason, people in the Gulf region were having very rare hypos out of Ramadan, which was 0%, and during Ramadan, 0.5%. Other regions, the maximum was 5% during Ramadan for Mediterranean countries. And the same with the meaningful hypoglycemia of less than 54 or 3 millimoles, 55 milligrams or 3 millimoles was also not too high. The maximum was 2.9% in South and Southeast Asia. So many, as I mentioned, over 40% were on SGLT2 inhibitors, and that's a very common combination nowadays. Now, when I think of this person, he's already on 3 molecules: basal insulin, GLP-1, and SGLT2, and possibly one or two of the other drugs as well, metformin or SUs. So when you look into the rates of hypoglycemia out of Ramadan for SGLT2 users in red, it was pretty low. When they fasted, it was 4.2%. And obviously, as I mentioned, the vast majority of them are on multiple therapy, which we know can cause hypos. But nevertheless, this is reassuring because it's pretty low. Very important that we apply dose adjustment. We empower our person with an algorithm to do the dose adjustment of therapy, up or down, whether they are hyperglycemic or hypoglycemic, so that they can get the better control and sustain safe fasting, and indeed, of course, out of Ramadan as well. So if we are to apply this process to Ahmed and apply what we did in the Aguilar Lexi and change his mixed insulin as a model, we did not do that in the study, but as it's been done in other studies, we can safely say, let's change your your Novomix to Aguilar Lexi, and let's see what would happen. And because of the low rates of hypoglycemia, one would be able to intensify the dose gradually and to address the peak of the postprandial peaks. So you would see here that you would be able to, in short time, get an improvement in HbA1c with far much less frequent hypoglycemia. So if I were to rescore Ahmed now, being on the fixed ratio combination of basal insulin and lixexenatide, so the GLP-1 doesn't score, but the basal insulin will score 1.5. The lower rates of hypoglycemia will score 1. The improvement in glycemia score would end up him being on a 0. So very interestingly, that his score now is 2.5, moving from high risk to low risk with simple treatment modification and education on top of it, and better advice on what to do and how frequent to check, and taking the right food at the right time, and empowering the person with an algorithm. So I'm sure Ahmed would be happy to apply this. Now, let's move track from the fixed ratio combination of GLP-1, lixexenatide, and basal insulin to another case scenario. Here we have someone who is works as a bank accountant with type 2 diabetes for 12 years. And he comes to you again well before Ramadan. He's on a statin, on sitagliptin and metformin, on dapagliflozin, and on glargine 100, taking 18 units. This was started 6 months ago as he was intolerant to GLP-1 receptor agonist because he has gastroesophageal reflux disease. He couldn't tolerate a GLP-1. So the option 6 months ago was to stop the GLP-1 receptor agonist and give him basal insulin glargine. Now, his results shows that he's only checking fasting. His fasting is still not perfect. His HbA1c has dropped from 8.3 to 7.7. He doesn't check at other times of the day. He gets the odd hypoglycemia since starting on insulin. The last was a week ago. He frequently eats healthy food, and he goes walking 2 to 3 times a week. He has no renal problem, cardiac problem, and blood pressure and lipid profile. Lipids profile are normal, and blood pressure was 135/70. And he wants to fast. He's concerned. This is the first Ramadan he's on insulin. So he clearly comes to you with a bit of conflicting issues, passionate about fasting, but concerned about being on insulin. And that's what would be in my mind. He's on basal insulin. He gets hypos about once a week or slightly less than once a week. His glycemic control is still not ideal. His SMBG frequency is also not ideal. He's a person that physically active and goes walking 2 to 3 times a week. So plenty of points that we would need to discuss with him. So going again through the systematic process rather than objective process. So he has type 2 diabetes, score 0. Here, the duration is 12 years. That scores 1. His hypoglycemia was over a week ago, so that's less than once weekly. That scores 1. He's on basal insulin. That's 1.5. His other therapy does not score. His glycemic control is still not ideal, and that scores 1. He doesn't have cardiac or renal problem or acute glycemic events. His control is his frequency of monitoring is suboptimal. He does check, but only in the morning, so that's considered to be suboptimal. And he has no other issues. So when you go to the risk score, you'll find that he's in the moderate range, 5.5, not too far from being in the high risk level. The question again is, let's use this tool to motivate and empower the person to address issues that they can do and we can do to improve the overall diabetes of the individual and safety in fasting. In fact, all his issues are potentially modifiable. So, of course, education is key here. And luckily, we have the application of Dar Safa, which includes education for people in English, in French, in Arabic, in Urdu, and other languages are soon to come forward, inshallah. It has the Dar Safa education program. It's self-explanatory, and it also has the beautiful Ramadan nutrition plan, which also is tailored to the BMI of the person, the plan for the weight of the person, as well as the type of food the person would like to have, whether Asian food, Gulf food, Mediterranean food, Maghreb style of food, lots of options. And the education definitely need to include the timing of the SMBG and the frequency of the SMBG. Of course, the importance of the pre-fast, end of fast timing between Asr and Maghrib, or late afternoon and sunset. But other times of the day are also important for prevention of hypo as well as hyperglycemia. What about the exercise? We do not want Ramadan to be a month of sleeping and staying idle. And what the recommendations are saying is, if the person is doing light to moderate exercise, they can do it at fasting hours. But the more intensive exercise, specifically if the person lives in a hot weather, then ideally it needs to be done in the evening when the person is able to eat and drink. Having a good suhoor that is rich in protein and having complex carbs at iftar time is important. Avoiding the simple sugars and the excessive amount of fat and sugar is important throughout the day. But what about the potentials of changing the basal insulin to a better basal insulin? We have seen this, and it's already been published in the Orion trial. The Orion trial was a study that was conducted in a large number of countries, and it included people who were already on glargine 300, been prescribed a minimum of 8 weeks prior to the month of Ramadan. And typical to any Ramadan studies, again, is the split between pre-Ramadan, during Ramadan, and post-Ramadan. And here, the dose adjustment was left to the individuals, the clinicians and their patients, or people with diabetes rather, according to what they feel is right. And the primary objective was hypoglycemia as the primary objective. Obviously, secondary objectives were there as well. The study included nearly 500 persons. They were of mid-age, mid-50s. Some of them were on the duration of diabetes. On average was 9.1 years. BMI was nearly 30. Small number of them were on the high or the very high risk, but the majority were on the moderate to low of the old risk scoring that was applied at the time of the study. Geographically, they were mostly from the Middle East, Gulf, and Asia, but importantly, there were 25 persons, 5% from Canada. And we'll come to this point in a moment. The average insulin dose per unit per kilogram was 0.32 before Ramadan, slightly lower during Ramadan to 0.3, and again going to 0.32 after Ramadan. So hardly any change in insulin dose, perhaps reflecting the base HbA1c, which was in the mid-8s. But the beauty is, even being on a basal insulin, such as glargine 300, did not stop people from fasting. 85% fasted the whole month, and another 11% fasted 25 days or more. So indeed, this is obviously quite encouraging because we know that our patients want to fast. What about hypoglycemia, the primary objective? Well, out of Ramadan, this occurred only in 2.2%, and the more clinically significant one of less than 54 or 3 millimoles was on 0.8% before Ramadan and nothing during Ramadan. The less than 70 occurred in 2.6%. So slightly different, marginally different than what happened during Ramadan, which reflects the pharmacodynamics of the drug and perhaps the understanding of the persons with diabetes about what they should do. So there was no severe hypoglycemia. But one interesting issue about the geographical distribution, I told you that in Canada there were 25 persons and the rest of the world were the other 474 persons. But interestingly, that the rates of hypoglycemia in Canada were 6 episodes and out of the rest of the world, 7. So it's another important point about thinking of the duration of fast, the underlying control, the intensity of the work during the day. Luckily, in many of the Muslim countries, the working circumstances and the working hours are modified. But that's not the case in many of the Western societies. So that means that the clinician and the person with diabetes need to understand this, check more frequently, and reduce the dose a bit more. By virtue of fasting, even though the dose was not increased, the HbA1c improved from 8.1 to 7.6, and the fasting improved from 144 to 128. And the SMPG also improved. By what? By them doing whatever necessary. They were empowered to have this information. Whether they applied it or not, it was not intention to treat the trial. And this is what we can do in real life by empowering our persons with diabetes with a good algorithm to adjust the dose up and down to achieve the target. And don't forget, for those who are on high insulin doses, 2 or 4 units means nothing. We need to move to 10 to 20% of the dose. We say for basal insulin to be taken at iftar. In reality, for ultra-long-acting insulin, glargine 300 or degludec, the timing doesn't matter because of its long duration of action. But reduction in the dose, specifically for those who are well controlled, would be advisable. So what I've shown you 2 different case scenarios, and we applied the theory into practice of either conversion from a mixed insulin to a fixed ratio combination of basal insulin and a GLP-1, or indeed changing the type of basal insulin to a better from a pharmacodynamic to reduce the risk of hypos. And in both studies and in both scenarios, you can see that hypoglycemia would be reduced while also improving on glycemic level, which is really crucial because that's a problem issue in our regions. So in conclusion, ladies and gentlemen, Ramadan fasting can be a challenge for some people as well as us as healthcare professionals. However, having a systematic approach with risk calculation is essential. Having the look into the treatment options that we have and selecting the type of treatment that suits the person is really quite important. Many of the risk factors could be modifiable with better choice of therapy, with better glycemic control, with better monitoring, and with less frequent hypoglycemia. Fasting Ramadan is not an excuse for treatment inertia by simply saying, okay, let's think about it after Ramadan is over. We can indeed intensify treatment or modify treatment to hit 2 birds with 1 stone, improve glycemic outcome, and have a safer Ramadan. All of this is essential with the support of good patient education and good frequent monitoring, which can make Ramadan a much safer outcome. Thank you very much all, and I hope you enjoy the conference.